Vital signs. All right, these are individual skills that we're going to have to hone and practice. The providers and mentors out there out in the field are going to require us to be very good at learning and then quickly adapting and coming up with these vital signs. This is part of our role. This is our duty as a EMS provider to gather adequate, accurate, and efficient vital signs. This helps us to determine how stable or unstable our patients are. This requires us to get a heart rate. We gather a heart rate by using a watch with a minute hand or a second hand so that we can watch the seconds as they move around, and we want to find a pulse. So we identify this pulse either the radial pulse, this is underneath the thumb on the radial bone, or on the inner aspect of the antecubital fossa, the bending of the elbow area, which we find a brachial somewhere up underneath the armpit, which is another brachial artery. We can use the carotid artery, the femoral, and the like. But we want to check for a pulse rate. Pulse rates can be fast or slow or normal. Normal heart rates range anywhere between 60 and 100. Anything over 100 is called tachycardia. Anything less than 60, we're looking at bradycardia. So 58, 59, 50, these are bradycardias. 60 to 100 is normal, and above 100 is tachycardia. Feel pulse rate for a minute. If it's very irregular, we're going to use the minutes, 1 whole minute to determine the pulse rate. If it's extremely regular, then we may use a 10 seconds, 15 seconds, or 6 seconds, and then multiply it appropriately for a minute. Respiratory rate. This will take a little effort in determining this. Unless they're breathing very heavily and you can see accessory muscles and they're very active in breathing. Usually, a patient that is not in any respiratory distress will not have any accessory muscle use, and breathing is very passive. So you'll have to watch their chest rise and fall in order to determine that. A respiratory rate, we would need again a watch with a second hand as it goes around. And we want to watch every inhalation and exhalation is 1. In and out is 1 breath. So we'll count amounts of in and out or amounts of breath in a minute if they're breathing irregularly, or if they're breathing extremely regular, then we can do 15 seconds, 10 seconds, 20 seconds, and then multiply it appropriately for a minute to get our respiratory rate. Now, normal breathing rates is anywhere between 12 and 20. Anything above 20 we would consider hyperventilation, or that is an accelerated respiratory rate, meaning that now they may be having some respiratory depression, or they might be in respiratory distress. Anything lower than our 10 breaths per minute, we start thinking that they might be hypoventilating. So normal ventilations or eupnic, tachypnic greater than 20. Hyperventilation is usually greater than 26. And then hypoventilations or bradypnea is usually less than 8 breaths per minute. Now, we'll have to talk about these breathing patterns later, as there's other breathing patterns that may cause them to be very slow, agonal and apneic, 0 breaths, and agonal being less than 6 breaths per minute, 6 to 8, but very regular. So we want to count those respiratory rates again. And that's about for a minute. Blood pressure, we know that we're using the right arm or left arm, whichever arm that is most accessible to you at the time. We want to put a blood pressure cuff on. It should be 1/3 the width, right? It should be 2/3 the width of the arm, so that there's 1/3 of the arm still exposed when we put it on the upper arm. So the width of the cuff. Then the length of the cuff. When we wrap the arm up, 2/3 should be underneath that. We shouldn't have a half, or it shouldn't be just tight enough for us to put the Velcro on. So we need to have the proper size blood pressure cuff. Place that on suddenly so that it's so snug to the arm that it won't slide off. We then want to identify the brachial artery and make sure that the cuff, those arrows are pointed to the artery, and that we have the sphygmometer, that dial, facing towards us so that we can read the blood pressure reading as we take it. Now we have the cuff securely on, we have the arrow pointing towards the artery, we have the gauge pointing towards us, and we can feel a pulse rate in the brachial artery. We're going to pump and aerate the blood pressure up, making sure that our release valve is tightened and closed. We're going to keep our finger on the pulse, that brachial pulse, as we pump up until we no longer can feel a pulse. Now, if your blood pressure cuff has gone up and you've pumped it up to 120, we're going to pump it up 20 millimeters of mercury more, or 20 increments more. So 120 plus 20 is 140. If you pumped up the blood pressure and it stopped at 100, we're going to go up 20 more, so 100 plus 20 is 120. If you pumped up the blood pressure and it stopped at 180, we're going to go up 20 more points. 180 plus 20 is 200. So always, whenever you pump the blood pressure cuff up and you lose the pulse, wherever you lose the pulse, we're going to pump it up 20 increments more. Then we're going to release the pressure valve and let the air pressure slowly deflate out of the cuff. This takes some practice. If you let it go too quickly, the gauge will blow right down and you won't be able to get a blood pressure because the dial just moves too quickly, and that arm will just deflate all the way down to zero. So we want to do it very slowly, sort of like that second hand on a clock, on your watch. So we're going to do it very slowly, and we're going to start listening for the sound as soon as we start to deflate. So you need to move your thumb off of that pulse rate and put your stethoscope right on there. Ensure that those earpieces are in. Release the pressure valve and slowly deflate the cuff and listen for the first sound. That first sound is the systolic number. Record that number. It should be the highest number. It's your start sound, systolic number. The done sound, when there's no sound left, there's no ticking, it's done, is your diastolic. Record that number. It should be a lower number than your start number. Your done number is lower than the start number. The start number is your systolic number. Your done number is your diastolic. You have a fraction systolic over diastolic, and that's your blood pressure. Now remember, your patients will have blood pressures that are not in the normal range sometimes, so just tell your mentor or your provider or your trainer exactly what you heard. Now, if you couldn't hear anything, explain to them that you couldn't hear it. They may want to take it themselves, or take the blood pressure cuff off and try the other arm. Temperature. We usually use oral temperature, as it's usually the most accurate, other than a rectal temperature. Now, keep in mind that we'll have to practice with the device that you're using that day. So we've gotten rid of all of these glass mercury type thermometers. They're usually electronic, and these electronic oral thermometers will have a plastic sleeve that goes over them. This keeps it sterile. So you place on a new sleeve, you place it under the tongue of your patient and have them close their mouth, and not to bite on it and not to talk. So it sits under there, and you hold the machine and the device in their mouth until the reading is shown. When it is done, you'll depress the back of the device, then separate in the sheath over the probe and dispense of that sheath into a trace receptacle. You may want to wipe that down later with some alcohol, but it shouldn't be grossly contaminated. The patient may also facilitate and help by holding the probe part just in their mouth with their hand. So they may be helpful in use. Now, there are other ways to take a temperature. There's a temporal temperature probe that runs across the forehead and rests right above the temporal artery. There's also a tympanic probe that goes inside the ear, where you have to find a good fit, and then not to press too hard into the ear canal, and you'll depress the device and allow it to read. Again, for pediatrics, we may use the same probe for the oral, but it may be for rectal. And so just find out which one they're using, and we'll use usually rectal for pediatrics, orals for our adult patients. Pulse oximetry we'll find is usually a single probe device. It may be a small little square box, probably about the size of a pack of gum, or it may be a device that's connected to the EKG machine. This reads through infrared, through a nail bed, the amount of oxygen that is floating within the capillary bed. So it shoots a light source through it that reads on the other side. The more oxygen, the less light source, or somewhat to that effect, and it registers the number. So we would like to see our patients with a number above 95%. That would be on room air. Now, if they're less than 95%, we may decide to give them oxygen or to support their ventilation. Again, the device we would watch to make sure that device, if we're providing oxygen and therefore or even ventilations, we'd like to see that number increase from 94 or below to the 95 range. The last vital sign, and this is usually in your textbooks, it's the pupils. So we want to use a independent light source like a pen light, and we're going to check the pupils. We're going to shine the light not directly into their eyes, but towards the corner of the eye, and we'll demonstrate this in class. But we're going to shine the light just on the corners of the eyes on both sides, so one on the right, then go to the left, and we're going to have them look directly at your nose. So you're not shining the light directly in their eyes. You don't want to blind them, and you want to tell the patients, I'm not going to shine this light in your eye, and I want you to look at my nose and focus on my nose only and not the light, because I don't want to blind you. You're going to shine the light towards the corner of the eye, the outer corner. As they look at your nose, you'll watch the pupils respond to that light. You'll move that light and touch the other corner of the other opposite eye to make sure that these pupils are correlating and dilating and constricting in response to the light. You might then bring the light closer to the center of their nose to see if they will react simultaneously. And then you might also cover one side with your hand, shine the light, cover another with the other side, and so forth. When we practice in the classroom, we don't have the ability to shut the lights off. But if you are in the back of an ambulance and there's the ambient light that we turn on in the back of our patient compartment, we might turn these lights off to get more accurate constriction and dilation of the pupils. So go ahead and practice these vital signs. Ensure that you are using your skill sheets and practice and practice and practice.